I'm Nyahita, Registrar from Department of Hematology, Singapore General Hospital. Deep vein thrombosis and pulmonary embolism are collectively called venous thromboembolism and are characterized by the formation of thrombus in the deep venous system of lower limbs and less commonly the upper limbs, with the potential for embolization to the lungs. Primary thrombus can also form in pulmonary vasculature and in other venous systems like portal or mesenteric veins or cerebral venous sinuses. The incidence of DVT among Caucasians is reported to be around 100 cases per 100,000 population per year, with a 2.5 to 4-fold lower risk among Asians or Hispanics. It is associated with significant morbidity and mortality, especially without appropriate interventions. The development of venous thrombosis was classically first described by Virchow, who stated the presence of stasis, hypercoagulable states, and vascular endothelial injury as essential triggers for thrombus formation. Risk factors leading to the development of DVT can be categorized under each arm of Virchow's triad and may be inherited or acquired. Venous stasis can therefore occur when there is immobilization or obstruction to venous flow by a tumor. Hypercoagulable states can be induced by inherited disorders like homozygosity for the factor V Leiden mutation, protein C or S deficiency, or antithrombin 3 deficiency, or due to acquired conditions like the antiphospholipid syndrome, malignancy, or drugs. Vascular endothelial injury is usually associated with trauma, surgery, or intravenous catheters. DVT can be asymptomatic. The symptomatic DVT patient will, however, present with unilateral limb swelling and pain with erythema, increased warmth and tenderness on physical examination. It is important to note that a difference in bilateral cuff circumferences is a strong clinical predictor of the diagnosis. Other important clinical information will include a positive personal and family history of VTE, use of hormonal therapy, travel history, and underlying medical and recent surgical history. In elderly patients with their first episode of DVT, a comprehensive history and physical examination to screen for malignancy, including breast examination, digital rectal examination, or gynecological examination, is strongly recommended. Clinical symptoms and signs of DVT are non-specific and can be unreliable in diagnosing DVT. Objective confirmation of DVT therefore relies on imaging techniques, with compression ultrasonography the overwhelming diagnostic test of choice. Despite the widespread availability, compression ultrasound is relatively costly and should not be used as a screening tool, but rather a confirmatory test in patients with high clinical suspicion. A pre-test probability scoring system such as the Wells score may allow the distinction of high-risk from low-risk patients. This widely used score looks at the presence of risk factors like active malignancy, recent surgery within 4 weeks, immobilization, and the clinical signs like localized tenderness along the deep venous system, swelling of the entire leg, pitting edema, collateral superficial veins, and whether there is a possible alternative diagnosis. High-risk patients should be subjected to further confirmatory testing. Conversely, a negative D-dimer assay and a low pre-test probability score may be used to exclude a diagnosis of DVT and mandate no further investigation. Tests for underlying thrombophilia are varied and should be chosen based on the patient's clinical profile. The factor V Leiden and prothrombin gene mutation should not be routinely tested among Orientals because of their low prevalence. In patients with newly diagnosed unprovoked DVT, the screening for an underlying congenital or acquired thrombophilia should be restricted to selected patients and be individualized. Screening for congenital thrombophilia should be considered in patients with strong family history of VTE, especially at age less than 50, idiopathic VTE, recurrent VTEs, and VTEs at unusual sites. Conversely, in an elderly patient with first unprovoked DVT, screening should be focused on the presence of malignancies with a thorough physical examination, chest X-ray, basic laboratory tests like full blood count. An acquired thrombophilia like antiphospholipid antibodies should be screened in idiopathic cases regardless of patient's age. Hereditary thrombophilia screening should only be performed if they have an influence on management decisions. As the risk of recurrence in the first year after discontinuation of anticoagulants is as high as 15%, patients with their first idiopathic VTE may be considered for extended treatment, even if the thrombophilia screen is negative. When testing for hereditary thrombophilic conditions, one should also know which factors can influence the results of the screening test before ordering one. Antithrombin 3, protein C and S levels can be lower than normal in the setting of acute thrombosis. Lupus anticoagulant cannot be tested in the presence of heparin, or it can be falsely positive in the presence of warfarin therapy. Similarly, protein C and protein S levels will be lowered by warfarin therapy. The main objectives of anticoagulation therapy is to reduce the risk of extension of the primary clot as well as early and late recurrence of DVT. Anticoagulation may increase the rate of clot lysis by the in vivo fibrinolytic system. Rarely, thrombolytic therapy or thrombectomy may be necessary because of acute limb ischemia. Adequate anticoagulation is essential to prevent the recurrence of VTE and reduce the risk of post-thrombotic syndrome. DVT is treated primarily with anticoagulants. Initial treatment is usually started with either dose-adjusted unfractionated heparin or low molecular weight heparin. Fondaparinux, a synthetic pentasaccharide with anti-tannic activity, as well as the new oral anticoagulant, rivaroxaban, can also be used. Long-term treatment usually involves the use of vitamin K antagonist like warfarin and rivaroxaban, which is a direct factor Xa inhibitor. Low molecular weight heparin is widely used for initial treatment and is given subcutaneously with dosing based on body weight of the patients. Accumulation can occur in patients with impaired renal function, and dosage adjustment is necessary. Anti-10A activity can be monitored mainly to prevent accumulation of the drug in chronic renal failure patients as well as in patients at extremes of weight. Warfarin until recently has been the only form of oral anticoagulation, and its effect is monitored by the International Normalized Ratio. An INR of 2 to 3 is recommended for acute VTE. Drug and dietary interactions are common with warfarin, and appropriate patient education and counseling are important components in warfarin management. Initial treatment has been with parenteral therapy, and warfarin should be overlapped with parenteral anticoagulant for at least 5 days. Rivaroxaban has recently been approved for treatment of acute DVT without pulmonary embolism and can be used as a single drug throughout the treatment period of DVT. Patients with contraindications for anticoagulation therapy may benefit from the placement of temporary inferior vena cava filter. Thrombolysis or thrombectomy is recommended in patients with limb-threatening massive DVT. Asymptomatic distal DVTs can be monitored by serial imaging. In the absence of progression, anticoagulation therapy may be withheld. The duration of anticoagulation for provoked DVT is now recommended to be until 3 months after the resolution of the provoking risk factors. For example, in a catheter-related DVT, if the catheter is essential for the patient, it doesn't need to be taken out, but the patient should be on anticoagulation as long as the catheter is present and until 3 months after the catheter is removed. There is no optimal duration of anticoagulation therapy for the patient with first unprovoked VTE, as the recurrence rate is high after stopping the anticoagulation therapy. Treatment duration should be tailored based on the stability of INR, patient's quality of life and wishes, and complications with anticoagulation. Risk of bleeding with anticoagulation therapy is reported to be around 2% per year of treatment. Prophylactic therapy is recommended for hospitalized, acutely ill medical patients during acute hospital stay, critically ill patients, patients with cancer and additional risk factors for VTE, general surgery patients with moderate to high risk for VTE, general surgery patients with cancer and high risk for VTE, and in this setting it is recommended for at least 4 weeks of prophylaxis, Major orthopedic surgery for at least 35 days of prophylaxis in major trauma patients. Post-thrombotic syndrome is a notorious complication in about 20 to 60% of patients with the first DVT. It presents with symptoms and signs of chronic venous insufficiency like pain, swelling, and skin discoloration of the affected limb. Prompt and adequate antithrombotic therapy for DVT and the use of compression stocking are still the main treatment options to prevent post-thrombotic syndrome. Thrombolytic therapy may have a potential role in patients with venous obstruction or reflux.